Hi, and welcome to another episode of the Healing Lyme Summit 2.0. I'm your host, Dr. Mariah Hinchy, and today we're going to be talking about cerebral folate deficiency and its possible links with Lyme and other co-infections. So, here with me today is one of my great friends and fellow naturopathic doctors, Dr. Lindsay Wells. Dr. Wells is the lead author on the recent publication on folate receptor alpha antibodies in the pediatric acute onset neuropsychiatric syndrome, or PANS, and PANDAS. She's also the co-founder of Lyme Heal Hers, which is an online summit focused on women and children suffering from vector-borne diseases, as well as one of the first naturopathic physicians to receive their fellowship from the Medical Academy of Pediatric Special Needs, or MAPS. For more information on MAPS, you can go to medmaps.org. So, welcome, Dr. Wells. It is an honor and a privilege to have you here with me. Tell our listeners a little bit more about yourself and how you came to specialize in pediatrics and vector-borne disease, and how you ended up being involved in and leading this study on cerebral folate deficiency.
Well, thank you so much for having me. So, as you said, I'm a naturopathic doctor. I practice in Trumbull, Connecticut, and I knew early on in my career that I wanted to work with the pediatric population. My heart was really with children with neurodevelopmental disorders like autism. I just find them to be so lovely to work with, and their family is amazing. And so I spent a lot of time working with children with autism, and then that kind of shifted into working mainly with children with PANS pandas. And so early on in my career with PANS pandas, you were seeing a lot of, for instance, strep causing the onset, or mycoplasma. And then what ended up happening was I was seeing cases that were getting harder and harder to treat, and there wasn't that waxing and waning presentation that we usually see around an infection. What we were seeing is that these kids were in what I call constant flares, meaning that every day was pretty difficult for that child with some neuropsychiatric symptoms, whether that was separation anxiety, OCD, behavioral regressions, academic decline. And it was getting really challenging for the children and the family members. And so we had to start exploring deeper, like what was going on with these kids. And what we were finding was it was almost disturbing, the findings of vector-borne diseases with these kids with PANS and PANDAS. And so it was mainly Bartonella that was coming up, which really made sense in regards to the neuropsych symptoms with these children, especially like the rage and the aggression and the anxiety and the OCD. But what's really also come recently in the past few years is also Babesia coming up right behind Bartonella in my population. So that's kind of how I got into this, was like just exploring deeper of like, what are these children suffering from, and why are they like chronically having these flares, and finding that the majority of them do have vector-borne diseases. So I had to, learn how to manage those infections. And what was beautiful is seeing that these children and these families started to get relief because we found out what the infection was underneath that were contributing to the immune burden for them to be presenting with the symptoms. So that's how I got into this field. And I feel very grateful and excited about it, that I can offer hope and answers to families who are experiencing this with their child.
Yeah, and we are very grateful to have you and all the work that you're doing. And really, like at large, this community is very lucky to have
Mhm.
someone like you that does not stop digging at
Mhm.
the root cause, right? Because, for a lot of people, it's like, oh, PANS pandas, that's, there it is, that's the root. And it's like, no,
Mhm.
there's always something deeper, causing that immune dysfunction that actually allows for PANS or pandas to occur. So,
Absolutely.
all right. So today, though, we're going to focus on cerebral folate deficiency
Yeah.
and the role that it plays. And for listeners that don't know, it plays a role in autism spectrum
Mhm.
disorder. It plays a role in PANS and PANDAS a lot of times. And also, it plays a role in a lot of neurodegenerative as well as neuropsychiatric issues.
Mhm.
So even beyond what we're talking about, just to get it on the radar, it's implicated in depression and anxiety, can be with Parkinson's, can be in dementia, stroke. Like there's just a much wider
Mhm.
array of issues that it can cause here. But Dr. Wells, start out by telling us exactly what it is.
So cerebral folate deficiency essentially is just not getting enough folate into the brain. So folate, we've probably heard about this nutrient, right? Being very important when a woman is pregnant to decrease neural tube defects, correct? Could also be helpful for anemia. But
Mhm.
what people don't realize is that we actually need folate in our brain to help with regulating neurotransmitters, to help with doing methylation, different pathways, to help with detoxification. And when we don't get enough folate into the brain, there can be consequences. Many of the things that you just, mentioned, on top of also seizures, schizophrenia, and then the biggest one is neurodevelopmental delays and autism, but treatment-resistant depression, dementia, there's many different, as I said, consequences or manifestations to cerebral folate deficiency, just not getting enough folate into the brain. And what's very interesting is you can have normal levels of folate in your blood. So say you test your blood just for folate and you're like, oh, there's plenty there. The levels look good. I must not have an issue. You can still have an issue and have cerebral folate deficiency because of particularly many different reasons, but particularly what we're going to talk about is the autoantibodies not being able to shuttle that folate into the brain, leading to the cerebral folate deficiency.
Right. So you can have plenty of folate in the body. And obviously, there are various forms of folate,
Mhm.
which we'll talk about. But
Mhm.
for everyone listening, it's not enough just to have a nutrient or a substance in the body. It has to be able to get to and bind to the receptor to actually bring about the physiological change or action that we're looking for from that nutrient. So why don't you tell us a little bit about the different forms of folate and tell us about the receptors and how like what is the like pathophysiology behind how this
Mhm.
arises?
So this is very like a simplistic kind of pathway that I'm going to talk about. But essentially, we get folate from things in our diet, especially like green leafy vegetables. That has to be converted in such a way that it can become bioactive, that the body can recognize it and plug it into its pathways. So it's going to go from folate to folinic acid to methyl tetrahydrofolate. That methyl tetrahydrofolate is the bioactive form of folate that, again, the body can utilize in its pathways. And so when we're talking specifically at the brain at the blood-brain barrier is a very tightly regulated system. And we're very fortunate for that, right? So not anything can just enter into the brain. But at the brain, there's going to be receptors. And I think of these as locks. And they have a specific key that can bind into it to be brought into the brain. So there are receptors on the blood-brain barrier for this methyl tetrahydrofolate. That methyl tetrahydrofolate is the key. It can bind into that receptor and then be brought into the brain to go through those many different processes that I discussed previously. But what can happen is that there can be abnormalities at that receptor site where there's actual autoantibodies that block the receptors that don't allow the methylfolate to get into the brain. So essentially, what happens then? That's when you have the cerebral folate deficiency and then may have those symptoms that we mentioned before.
So someone could even be taking methylfolate. But if you do not resolve the issues that are binding or blocking to the
Mhm.
receptor and inhibiting the methylfolate from attaching like the key to the lock, then you're still going to have the issue.
Absolutely. So a lot of people will say, well, I have the MTHFR mutation, and so I'm taking methylfolate, so I should be good, right? That's not the case because when you have these autoantibodies, there's two types in particular that we focus on or test for. One is blocking, where the antibody literally blocks the receptor so no methylfolate can bind to it. So it doesn't matter how much methylfolate you're taking. On the other side, there's something called the binding autoantibody, and that can bind to anywhere on the receptor and essentially alter its shape so it doesn't function optimally, so you can't get enough in. So really what's interesting and what the research has found is that you essentially need to flood the system with folinic acid, which is a step above methyl tetrahydrofolate, to access a different carrier transport system in the brain to then bring in the folinic acid. So that's
Okay.
how that works.
But then there's another piece to it too, right? Because that wouldn't be enough. So tell us about the molecular mimicry with dairy and
Yes,
how dairy is actually one of these underlying like root causes of how this would even occur
right.
in the first place.
So there's two ways that we know of that somebody could have cerebral folate deficiency. One is a non-genetic hereditary type of process that occurs. So this is something that somebody possibly could be born with, right? And what we see is that there is some um, like mothers and fathers can have this and siblings can have it even if they don't have the manifestations from it. The other piece is that we can get this from consuming dairy products, and this is all animal dairy. Most of the research is just with cow dairy, but we kind of make the assumption that it's all animal dairy. So what happens is molecular mimicry, that with cow dairy, what we know is that the folate receptor autoantibodies, those antigens are about 90% like homologous to what we have in the antigens in our body. And so when we consume the dairy, what happens is our intestines will actually make those autoantibodies itself. And so when we're drinking the milk or taking the dairy product, we're just essentially causing our body to make more of those autoantibodies. And then what that's doing is it's blocking the receptors on the brain. And so one of the biggest treatments besides giving high dose folinic acid is removing all animal dairy from the diet completely. And it's so interesting. There's been some research, not much, but looking at this to see how the autoantibody levels drop significantly when somebody takes dairy out of their diet, even when you're not giving high dose folinic acid. The high dose folinic acid is essentially just giving your brain the folate that it needs, right? But in order to bring down the autoantibodies, you have to remove the dairy. And then when you reintroduce the dairy, how it almost skyrockets again
Right.
those folate receptor autoantibodies. So that's a very important piece of the puzzle because a lot of times when people want to, go through treatment, it's much easier to take a pill of
Mhm.
folinic acid than it is to modify their diet. But it's almost like you might get some relief from it, and you probably will, just not to the extent that you could, find relief from symptoms. And really, long-term treatment is the two of them together, the removal of animal dairy and also the implementing high dose folinic acid.
Right, and it's almost like, this can be reversible if
Mhm.
you do both things together.
Yes.
It might not be reversible to the point that you can eat dairy again, but
Mhm.
you can resolve the issue by taking high dose folinic acid and avoiding all dairy products. I just want to make one point to our listeners. So, this is not something where, you would go and have a food sensitivity test, like looking at IgG or
Mhm.
IgA. This is not something where you would go to an allergist and have an IgE towards
Mhm.
dairy or casein or whey or any component of animal dairy. This is something completely different where the immune system gets triggered and confused because of the dairy and makes these auto antibodies. So I just want it to be clear, if you've had dairy ruled out, as an allergy, that has nothing to do with what we're talking about.
You're
Um,
absolutely correct about that because you're not looking for a antigen or the immunoglobulins against dairy. You're
right,
looking for folate receptor autoantibodies. So they're
right.
completely separate, and you can have somebody that does not have a sensitivity, does not have an allergy to dairy, but yet they are very positive for the folate receptor autoantibodies. Or vice versa, somebody who is sensitive to dairy or allergic to dairy and they don't have the autoantibodies against the folate receptors. So therefore, they do not have cerebral folate deficiency. And that's a great point. And another thing I want to bring up is, and just kind of reiterate, is The same thing with the MTHFR mutation. I feel like a lot of people get hung up on that thinking, okay, well, if I have MTHFR, I have cerebral folate deficiency. They are two completely separate things here. The MTHFR is a genetic mutation that you're not able to, convert your folate to the bioactive form as well as you should be. So there
Right.
you have a harder time going from folate to the methyl tetrahydrofolate. When the cerebral folate deficiency is just because one of the biggest reasons is those autoantibodies. And you can have autoantibodies without having MTHFR,
Right.
or you can have MTHFR without having cerebral folate deficiency. So that's a very common question that I get as well, or an assumption that people make. Well, I must have that too because, or my child must have that because they have MTHFR. It's completely separate.
Right. So before we move on to talking about potential links between
Mhm.
really severe neuropsychiatric symptoms in Lyme and the possible connection, tell me a little bit more about. I want to talk about why treating with folinic acid is more important than using methylfolate. And then also, I want to talk about testing for these autoantibodies.
So the research for cerebral folate deficiency is really done with leucovorin, which is a folinic acid medication. And so that's where we have the majority of our research. But also clinically, we see much better outcomes using folinic than we will with methyl tetrahydrofolate. So folinic acid, when you use high dose folinic acid, it has been shown to allow for the reduced folate carrier. So it's a different carrier that's on the blood-brain barrier to shuttle in the folate. So essentially that one gets activated when there's high extracellular, so a lot of folinic acid in the system to move it in. We don't have as much evidence that that occurs with methyl tetrahydrofolate. And so I think there's only been like one study or so that has shown that you could have the same effects. But again, clinically, in my practice, I have many children and adults with cerebral folate deficiency, and we always see more resolution in their symptoms by using the high dose folinic acid.
Okay, great. And so now, if someone wants to get tested to see if they have this autoantibody process
Mhm.
causing cerebral folate deficiency, what testing do you recommend and explain the testing a little bit more?
Yeah. The company and the lab name is Religion, and you can go online at fratnow.com to find information about the test, to find information about how to order a kit. You likely will need a physician name in order to get a kit, but you can inquire with them. I think they also have a list of providers as well. So providers who are ordering this test, if maybe you want to establish care for them, for yourself or your child. And what I also love about their website is they have a lot of the research out on cerebral folate deficiency. So if you do love to read the research, you can kind of find it all in one place there.
Are there any prevalence numbers in in the Lyme community as far as like the prevalence? I haven't seen any studies, but I know that you look at this very closely
Yeah.
with your patient population.
Yes, so there is no research out right now in regards to cerebral folate deficiency in tick-borne disease or vector-borne diseases. And this is something that I'm very passionate about, as I know you are too. And I've been scrubbing my own data, and the data actually looks very promising that about 50% of people who have vector-borne diseases are also positive for the cerebral folate deficiency. This is obviously pre-published, but it's part of my mission to get this out, this information out. And so I'm still pulling that and going to explore a little bit further of the ones who are positive, what symptoms are they manifesting? Because my suspicion is these are patients who have tick-borne diseases and are experiencing neuropsychiatric symptoms from the vector-borne disease. So whether that's, significant depression, anxiety, OCD, brain fog, memory loss, like dementia type symptoms, bipolar type symptoms. Like this is what my suspicion is.
Right.
But the prevalence looks very interesting here. And so hopefully I'll have that, you'll partner with me, Mariah, to do that, and we'll get that information out.
Yeah, I would love to. I'm, as you know, fascinated in the same
Mhm.
area. And yes, hopefully by the time, this is airing in April, we will be way underway to have those
Mhm.
answers to share with all of you listening. Because it really would be fascinating. There's a lot of this vector borne disease patient population that have way more neuropsychiatric and cognitive issues than they do musculoskeletal.
Mhm.
And again, it would be so interesting to see if this is part of what's playing that role. Okay, so let's transition into talking about treatment. So obviously, we've alluded to, you know, using high dose folinic acid and removing dairy from the diet. What else do you look at when you are treating patients that have cerebral folate deficiency?
It's a great question. I will look at some other markers too, like looking at other B vitamins. I'll look at their blood cell counts, their liver and kidney function, their mitochondrial markers. But really, the big treatment here is doing the high dose folinic acid and removing the dairy. And just that in general brings down a significant amount of inflammation, actually. It helps improve their detoxification pathways. And it also makes their like the other treatment, that they're doing more effective. And we see this actually in the treatment resistant depression
Mhm.
population, where the studies are ranging from about a third to over a half of patients who have treatment resistant depression have cerebral folate deficiency. And when high dose folinic acid is added to their treatment plan, they are finding moderate to significant relief in their symptoms when added with their psychiatric medication that they were taking. And
Wow.
so I also am finding that in my practice with people not necessarily using psychiatric medications, but with them just going through treatment, right? Of antimicrobials, more immune support, anti-inflammatories. And it's like we're seeing more improvements in their symptoms, adding in this piece than we are, with not having it in.
Yeah. And it's important to talk about too. I think sometimes the level of anxiety is literally debilitating. So it's like it's hard for these patients to even be able to follow
Mhm.
any simplistic treatment protocol. Not that, treatment for vector-borne disease is all that simple, but I mean, it makes it very, very hard for them to carry out their sort of like daily living
Yeah.
tasks. And so when you can bring down the level of anxiety or the level of confusion, just
Mhm.
those two things
Yeah.
alone, it actually enables patients to then be able to look at the bigger picture and do a lot of like the dietary interventions and, expanded protocols
Right.
that it takes to really heal the body from Lyme and co-infections. Couple questions. So
Yes.
when you say high dose folinic
Yes.
acid, what does that mean? Because this typical supplement on the market is 800 micrograms.
Right. Right.
What are
And
we
so
talking?
the high dose in the literature is 2 milligrams per kilogram, up to 50 milligrams per day. So we're talking 50 milligrams for most people,
If you're an
even
adult. Yeah.
even children,
Yeah.
who it's significant at 2 milligrams per kilogram. And it's kind of surprising when you have, a 5-year-old in your office and they need to be up to 50 milligrams. But yet you then have to tell them they have to take, you know, almost 2 bottles of what's available on the market
Per
per
week.
day,
Oh, yes, sorry, per day. Yes.
per
I
day.
had I had a parent for a less than 2-year-old crushing 15 tabs
Yes,
twice a day. Yes,
yes,
and I think their supplement was costing them around $600 a month
right.
just
And
to take this.
yes. And so there is a pharmaceutical available on the market. It's called leucovorin. And leucovorin can be prescribed by physicians. What I find is that it's very challenging to find a physician to prescribe this because leucovorin is classified as a chemotherapy drug because it's a rescue for chemotherapy. It helps to replete the folinic acid and the folate that's essentially depleted from going through chemotherapy. So in my population, I have a child and they need to go on folinic acid, and maybe I'm working with a pediatrician or somebody who has prescription rights and saying, well, they prescribe folinic acid, and then they look at the parent like, I'm not going to prescribe your child a chemotherapy drug.
Right.
So that's one challenge. The other challenge is that leucovorin that's available on like just through the regular pharmacy, a lot of times actually has dairy product in it, has some lactose in it. So it goes against what we're trying to accomplish because we're also telling the family you have to remove dairy. But yet
Right.
we're then giving the medication that treats this condition and giving them dairy product with it. So then the
Right.
other option is to get it compounded. And when you get it compounded, it can be extremely expensive and it can range depending on the price, depending on which compounding pharmacy you're using. And so there are some challenges here in regards to treatment.
Yeah.
Yes.
Okay, so how long does it take if someone is very diligent? So let's say they
Mhm.
remove dairy 100% from the diet
Mhm.
and they start taking the appropriate dose
Yeah.
of folinic acid. In your experience, how long does it take before you start to see a change?
You know, it's a spectrum, right? And so sometimes I'm amazed by how quickly I can see it. Like I can see it by the next appointment, right? Which might be 8 weeks.
Hmm.
Or realistically, I think it's going to take at least 3 months. The reason being is with dairy in the system, I think, the immune response to that can take some time to go down, right? So tell patients to realistically give it at least 3 months, but it's surprising because a lot of people will see it before then. And I think even in the research, when they're looking, say again, at treatment-resistant depression, they're looking at the trials, it's not very long trials. It's still around that 3 month mark, like the 12 weeks that they're kind of seeing what the improvements are. So that's usually around the time. However, I do treat for longer than that though. So just because you get, the results that you're looking for around then, I will continue to treat for a minimum of a year. Most of the time, depending on what the result is, I will treat longer than that.
Okay. And is there anything that you would like to share from the study that you were the lead author
Yeah.
on with our audience?
Yeah, so the study that we published was the first in the population for pans and pandas. It was also looking at prevalence. And so what we found was that 63.8%, so almost 64% of children who were in our study group were positive for the cerebral folate deficiency due to having either the binding or the blocking autoantibodies. What was so interesting about the kids who were positive where we had some that had some overlapping comorbidity with autism. And when we looked at the children with autism versus the ones who had just pans and pandas, their levels were actually much higher than the children with autism, which is really fascinating being in, my world and in my community because cerebral folate deficiency is so prevalent in children with autism. So it's like, what does that mean that these children with pandas have much higher levels than the children with autism? It was just that's interesting and it's a question mark and I don't quite know. But the
Right.
other thing that was interesting is that those who had higher levels of, for instance, the binding autoantibody, they were more likely to have tics. And so this could be something that's, more prevalent maybe in the Tourette's population. We don't quite know. Or the children who have childhood tic disorder, which is very common. Are they the ones with the cerebral folate deficiency? And is that then predisposing them possibly to having immune dysregulation? And they could present with pandas down the line. Maybe.
Right.
I don't know. Um, so that was fascinating. What we also found clinically is that the children who had cerebral folate deficiency, when we treated them again with the high dose folinic acid and took out the dairy, they had significant improvements in their symptoms. And so this was the OCD, the anxiety, the tics, the depression. And what I'm most interested in as well right now is looking at speech disfluency. So about 50% of children with PANS will have some form of speech disfluency. So that could be stuttering, that could be mutism, that could be, putting in words and not really being able to get their thoughts out. And I've had some cases in my office that those children that present with it are positive for the cerebral folate deficiency. And when we put in the high dose folinic acid, this, for instance, the stutter completely resolved. And so this is something that, again, I just find fascinating in the population for pandas. And it really made me curious because my population really is the ones that have underlying tick-borne disease with pandas. Like, is it the, you know, how is this playing a role in tick-borne disease and not just pandas,
Right.
and how this all comes together and really the symptom relief that we can get these people regardless of the infection and the immune dysregulation. Because, like you said, even being able to bring down the anxiety, being able to bring down that brain fog and helping with mental clarity could change somebody's life in regard like their and how they are able to get through and move through treatment. I mean, it's just going to improve daily living significantly.
Right. And if you look at all of the other actions of folic acid in the body too, right? Like you're right. Like it could actually explain why some cases of, even if we just looked at Lyme as that vector-borne disease, why some patients can have such severe neurological conditions, even with neuropathy and things like that,
Yes.
right? Versus, somebody else.
Yes.
Um Question, because so this just popped into my head. I would imagine that a lot of our listeners are experiencing the same. So what's the harm in taking high dose folinic acid? Like, are there potential side effects? Is there a downside? Is
Yeah.
there a point where, too much is too much? And
Mhm.
what would that look like? Talk us
Yeah.
through that.
Yeah, so what can happen when you put too much folinic acid in too quickly is there can be some side effects, mainly agitation, and irritability. That's the number one that I see. And the second one is insomnia. So in the literature, they're also going to put aggression down, but I don't see that clinically. So it's the agitation, the irritability, and insomnia. Essentially, what's happening is that the neurotransmitters are almost kind of like depleted from not having this folate in the brain, right? And so all of a sudden you're flooding the system with it. And what you're kind of overwhelming the synapses occurring at, say, serotonin neurotransmitters, the dopamine neurotransmitters, and it can cause an increase in some of those symptoms, right? And so that's when you go too fast and too much. And so I think kind of staying in that weight dependent range up to 50 milligrams is very safe, but it's how you go about implementing it that is what you need to watch. So usually I start at much lower doses than what their weight dependent dosage is and move slowly. And sometimes I move faster than I think some of my other colleagues. Like I'll keep going up every week. And then if somebody has those symptoms, I just bring it back down and hold there for, 2 weeks before moving up again.
Right.
But sometimes in like the literature, what they're saying is like you can go like every month, kind of increase it up. But my patients and my clients that come, a lot of them are really suffering, right? So I try to get them the relief that I know is possible in a quicker time frame because I'm able to help them through, okay, you're experiencing this, let's back down and let's, try again at this
Right.
time and kind of give them the instructions. But, you know, again, in the literature, what it's saying is that it is a very safe intervention. And if you are suspecting this, that it might be worth doing a trial of putting it in for a period of time without necessarily doing the testing.
Right. So you're saying you have a weight dependent target dose that you want to reach. Where would you start? Like, how would you derive your starting dose? And
Mhm.
how many weeks do you typically, like for the typical patient,
Yeah.
do you take to achieve that target weight dependent dose? So you're going to start at X and you're going to arrive at that
Yeah.
target dose, but like over how many weeks? And, do you double every week or 2 weeks? Like, how do you work up to it?
Yeah. So again, it kind of depends on the person and how big they are, but usually like and how sensitive they are. That's another
Yeah.
thing, right? If you're somebody or your child is super sensitive, they react to everything, you're gonna want to start lower than what I'm gonna say right now. But I think 7.5 milligrams is actually a pretty good place to start. And so I'll do that for a week and then every week increase it by 7.5 milligrams up into the weight dependent. Personally, I find 30 milligrams to be like a sweet spot a little bit for people, and I'll see something around that time. And if I'm seeing an improvement, I will kind of go quicker to get to the end goal. But you don't want to rule out that the intervention didn't work for you unless you're kind of at that weight dependent dose for,
Right.
as I said, a period of time, which minimum is going to be 3 months. I really think it should be up to a year for treatment there.
Okay.
Mm.
All right. Well, any last words of advice that you'd like to leave our listeners with? I would love to keep talking, but we are pretty much out of time.
Okay. Well, this has been wonderful, but I think the biggest thing is this should be explored. If you or your child are experiencing neuropsych symptoms associated with vector-borne diseases, this could be an additional piece that's not necessarily infection-driven, but perhaps there was a susceptibility that occurred beforehand or a dietary, you know, intervention that you could implement to get relief for those symptoms. And so there's still so much information that we need to figure out regarding cerebral folate deficiency in this population. But as I said, when looking at my data, it is very interesting and also promising that this could be just a piece of the puzzle that's occurring for you to get you relief from these persistent symptoms that you're having, just to make life easier for you while you're navigating, this vector-borne disease and this illness. And so I encourage people to explore further, and I wish more practitioners also would be testing for this because it can make a difference in the outcomes of treatment plans.
Yeah, absolutely. So, are you taking new patients?
I am taking new patients,
Okay.
but there
Tell
is
our
a bit.
listeners how to find you.
Yes, so you can go on to my website, which is lindsaywellsnd.com. And so all the information about my practice is there. And you can also find me on Instagram, Lindsay Wells ND. And I do love to post about vector-borne diseases. I love to post about PANS and PANDAS, cerebral folate deficiency, and you can find more information there. And you can also check out my paper that I did write in regards to the pandas population, and hopefully you'll see more coming out about cerebral folate deficiency specifically for this population.
Awesome. Any upcoming events you'd like to share?
Um, this upcoming event that we have going on is the Lyme Heal Hers event. This is a free online summit, and it's focused on women and children who have vector-borne diseases. This year, we're going to be focusing more on neuropsychiatric manifestations of vector-borne diseases, but it's a free online event. It's occurring January 31st to February 2nd, and you can sign up for free at lymehealhers.com.
Awesome.
Yes.
And by the time this actually airs, that will have been over. So you'll have to catch the replay,
Yes,
which will
thank
be
you for that. Yes.
sometime in the summer of 2025, I guess, by then. So
Yes, so we will definitely have an encore going on, but you can always check out the recordings on the website. Thank you for that, Mariah.
yeah, absolutely. All right. So thank you so much for being here, Lindsay. And for all of our listeners at home, thank you for joining us. And I truly hope that this helps you on your journey to healing Lyme. Take care. We'll see you next time.